checking the link. No, I didn't understand what you said. Okay. I was posting again the link so everybody will be tuned.
It's like a constant war, and you wanna settle that score, but you're bruised and beaten, and you feel defeated. This goes out to the heaviest heart. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out in the dark, into the light. It's not over, hope is rising. Never give in, never give up, it's not over. Yeah, whoa. Yeah, whoa. Oh, game, set, match. Time to put it in your past. Oh, feel the winter leaving. It's redemption season. Long live the young and high. Cheers to a brand new start. We're revived and breathing to live a life of freedom. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're Yeah, whoa. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up, it's not over. Yeah, whoa. Yeah, whoa. Oh, to everyone who's hit their limit, and even when you think you're finished. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa.
Currently the treasurer of the ILAE. Oh. Good evening, everyone. Thank you for joining us. It's my pleasure to present Professor Helen Cross, the next president of the ILAE from the term 2021 to 2025. She is the Prince of Wales Chair of Childhood Epilepsy and head of the Developmental Neuroscience Research and Teaching Department at UCL GOSH. She is an honorary consultant of the in pediatric neurology at GOSH and the Young Epilepsy in Linkfield, UK. She has been working on improving outcomes in early onset epilepsies, specifically in assessing the role of surgery and ketogenic diet. She also has held key leadership roles both nationally and internationally, and she's currently the treasurer of the ILAE. She's a clinical advisor to the National Children's Epilepsy Surgery Services for childhood epilepsy between 2018 and 2021. She developed as a coordinator of the European Reference Network for Rare and Complex Epilepsies, EpiCare, that was launched in 2017. And she has received the ILAE Ambassador for Epilepsy Award in 2007 and is a recipient of the American Academy of Neurology Sidney Carter Award and the IGNA Frankfurt Award and the American Epilepsy Clinical Research Award. So, Professor Helen, it's a pleasure to have you here. Welcome to this YES webinars, and thank you for accepting this invitation.
Thank you. It's my pleasure to be talking to you today. And my topic will be about the cannabinoids in the treatment of the epilepsies. Not least, I've had quite a lot to do with some of the development of the cannabidiol, and particularly the clinical trials, and have a huge interest in moving this forward in a safe and effective way. These are my disclosures. So what are we talking about? Well, when everybody thinks about particularly what is alluded to as medical marijuana, in the most part, looking at the cannabis, it's cannabis sativa. It's been one of the most widely used recreational and medicinal drugs worldwide. And it's probably likely to have been the first non-food plant cultivated by humans. So it's been around for a very long time. But of course, it's probably best known for its psychoactive constituent, tetrahydrocannabinol. If we look on the internet, it appears that medical marijuana or medical cannabinoids are useful for a variety of different conditions, not least epilepsy, but also neuropsychiatric disorders. It can act as an antiemetic and also has anti-inflammatory properties. And in fact, if we believe what is to be said about it, it can affect and help with practically any disease that may manifest to us. But what about its effect in epilepsy? Well, there is a large preclinical evidence base looking at the effects of cannabidiol, the main constituent, as well as the tetrahydrocannabinol, as well as looking at many other different components that there are within the plant. And essentially, most are seen to be anticonvulsant. But there are concerns in some animal models that a THC or tetrahydrocannabinol could be proconvulsant. And indeed, more recent evidence suggests that some of the effects may be species specific, and therefore animal models may not be the best illustration of effects of individual components or indeed the cannabinoids. With regard to looking at its effect in epilepsy, as recently as 2014, there was a Cochrane systematic review looking at evidence base with regard to particularly cannabidiol was used in the treatment of epilepsy. And at that point, they did find 4 randomized controlled trial reports, but there was a very small number of patients, only 48. One report was an abstract and another a letter to the editor. And from the conclusion, because of the lack of data, they said there was no reliable conclusion could be drawn regarding the efficacy of cannabinoids as a treatment for epilepsy, although then went on to say that a dose of 200 to 300 milligram daily of cannabidiol had been safely administered to small numbers of patients for a short period of time, although the safety in the longer term could not be reliably assessed. There was gained a lot of interest in the use of cannabidiol-enriched oils after a report internationally of a little girl in Colorado with Dravet syndrome, whose mother had researched this and thought in this particularly difficult, complex epilepsy, where seizures continue despite our standard antiepileptic drugs, researched the possible benefits of cannabidiol and sourced an enriched oil in Colorado where it was legal to do so, and was trialled, and it appeared to have a significant benefit, moving from 300 seizures a week to around 5 seizures a day. And then there was this subsequent report, a survey, a Facebook survey put out to families who perhaps had utilized cannabidiol oil, enriched oil in their children, self-sourced rather than prescribed. And there was a particular, this was only 19 children that were where the families reported and answered the survey. And indeed, we have to bear in mind this is a Facebook survey, and therefore there may be a degree of bias in the way that this was responded to. However, of these 19, 13 had, the children had Dravet syndrome, and you could see that more than 50% of the children were reported to have a more than 80% decrease in seizures. There were various other benefits that were reported, including decreased self-stimulation, better sleep, increased alertness and better mood, but also other side effects such as appetite decrease, fatigue and drowsiness. That aside, the reports were that it had been of benefit in this small number of children. GW Pharma, now Greenwich Bioscience, had been investigating the role of cannabinoids, and particularly the role of cannabidiol in epilepsy since around 2007. CBD, cannabidiol, is one of 2 major cannabinoids in Sativex, which is utilized for spasticity in MS. Epidiolex is an oral solution of pure plant-derived cannabidiol. And the advantages of this over that there may be self-sourced and the oils that they had repeatedly evaluated standardization of procedures for development of the plants, and thereafter the development of the actual compounds in a pharmaceutical way to ensure quality assurance, and therefore utilizing Epidiolex could be regularly produced in a consistent way, that we know that there's the same amount in each individual batch of medication. Initially, following the considerable interest, this was utilized in an open label study, cannabidiol, for the treatment of treatment-resistant epilepsy. 6 sites in the US obtained an IND from the FDA to utilize cannabidiol in a set of patients with continuing seizures with epilepsy. And these results were reported in the Lancet Neurology in 2016. And you can see that 214 patients were recruited across the different sites. And but there was a degree of safety and tolerability that could be evaluated, as well as an efficacy analysis. And each individual blue bar is the response of individual patients. So those above the bar got no benefit. Those under the bar and the negative from the on this side down here on the right, falling below the line, showing a positive response. And you can see that this was in the blue, this was the 12-week treatment period. So benefits seen in about 2/3. And you can see n equals 15 is over the final 4 weeks of treatment were completely seizure-free. Whereas this n equals 5 here was seizure-free for the whole treatment period. There was some evaluation with regard to proportions with Dravet Lennox-Gastaut syndrome. And you can see that 37% with Lennox-Gastaut syndrome and 49% with Dravet syndrome had more than a 50% improvement in seizures over the 12-week treatment period. But of course, this was an open label study. That aside, what was also determined was the role of clobazam, in the sense that in the multiple logistic regression analysis, clobazam use was the only independent predictor of reduction, more than 50% in motor seizures. Of course, subsequently, randomized controlled trials were performed. And the first study reported with the randomized controlled trial of Dravet syndrome, patients randomized to receive either cannabidiol in a dose of 20 milligrams per kilogram per day or placebo after an initial dose-finding study. And you can see that 117 were screened, 120 ultimately randomized, and completed treatment 52 in the cannabidiol group and 56 in the placebo group. The primary endpoint was the percentage reduction in seizures from baseline of convulsive seizures during the treatment period, which was the 2-week titration plus the 12-week maintenance. And you can see from these charts, both with regard to convulsive seizures and total seizures, there was a significant reduction in seizures utilizing cannabidiol in comparison to placebo, both in the whole treatment period as well as the maintenance period. Of course, there were treatment emergent adverse events. One of the most common were somnolence, diarrhea, and decreased appetite. But also there was some concern about derangement of liver function tests. And this was the time when we'd only started to use it. Certainly increases in transaminases were seen in 12 CBD patients, all of whom were on concomitant valproate, although none of the patients met criteria for drug-induced liver injury. 3 CBD patients withdrew from the study because of elevated transaminases because they met the criteria, although we since determined that with time, then the transaminases do appear to stabilize. And as I said, there is not a risk of moving to liver failure. And of course, there were then a further 2 studies, randomized controlled trials, the utilization of cannabidiol in Lennox-Gastaut syndrome or seizures associated with Lennox-Gastaut syndrome. 1 placebo randomization to placebo or 20 milligrams per kilogram per day of cannabidiol, whereas the second study, there were 2 doses of cannabidiol. So it's a 3-arm study, placebo versus 10 milligrams per kilogram per day cannabidiol versus 20 milligrams per kilogram per day cannabidiol. And you can see that, again, there was a significant reduction in drop seizure frequency during the maintenance period. You can see that this is seen relatively early on and is sustained through the treatment period. And indeed, there was an effect demonstrated with cannabidiol at 10 milligrams per kilogram per day, and only a marginal increase in benefit with 20 milligrams per kilogram per day. And not only seen in drop seizure frequency, but also in total seizure frequency, and this by 4-week period. And in total seizures, you can see there's very little difference between the 2 different doses of cannabidiol. What we've seen also, however, and this is combining the data from both studies, they were the same methodology. And you can see that if side effects are going to occur, they tend to occur early in the treatment. And again, the cannabidiol group have a mildly increased side effect profile in the 20 milligram per kilogram group rather than the lower dose. And subsequently, there was a further randomized controlled trial in Dravet syndrome, which looked, whereas the original study just had placebo versus the higher dose of cannabidiol, 20 milligrams per kilogram per day, this study looked at 2 different doses of cannabidiol and again showed that actually in reduction of seizures, whether you look at it percent reduction compared to baseline or indeed responder rates, you can see there's very little, there's an effect shown at the lower cannabidiol dose compared to the higher cannabidiol dose. So there's very little difference between the 2. And again, most common side effects were decreased appetite, diarrhea, somnolence, pyrexia, and fatigue. Certainly appetite and somnolence seen more commonly with the higher dose of cannabidiol. And there have been subsequent open label extensions reported of both these studies showing that the benefits are sustained over time. So there does not appear, once the benefit is seen, then it is sustained. There does not appear to be a degree of tolerance achieved in the longer term. Interestingly, when we look at mechanism of action, it doesn't appear to be acting on the epilepsy through the endocannabinoid system. And cannabidiol has been demonstrated to reduce neuroexcitability through antagonizing the GPR55 receptors, reducing calcium release from intracellular calcium stores and decreasing calcium levels, potentially modulating neuroinflammation, desensitizing TRPV1 channels, and also inhibiting ENT1 adenosine reuptake pumps. So acting at the neuronal junction rather than actually necessarily through the endocannabinoid system. So one also could argue, why have we only looked at Dravet syndrome and Lennox-Gastaut syndrome? And is it specifically efficacy that we may see related to these 2 syndromes? And the evidence we have is that actually, no, it's not. These mechanisms are general in reducing neuronal excitability. And indeed, we know, looking at open label studies, benefit from cannabidiol can be seen across a range of different types of epilepsy with different etiologies. There's the open label study reported by Hess and colleagues with tuberous sclerosis complex, again demonstrating response. There has, of course, been a randomized controlled trial utilizing cannabidiol in epilepsy associated with tuberous sclerosis that is positive, although yet to be published. It's also been demonstrated to be of benefit in fires, whether it be acute or indeed in the epilepsy in the chronic phase, and also epilepsy in this very small study associated with Sturge-Weber syndrome. And this is a more recent study reporting on epilepsies associated with a range of etiologies, Aicardi syndrome, CDKL5, Dew's syndrome, and duplication 15q. And you can see that there is a benefit demonstrated regardless of the etiology. But the other issue that has constantly risen has been the interaction with clobazam. And especially following the original open label study, with the only predictor of independent predictor of a response be on multiple logistic regression being coexistence of treatment with clobazam. And indeed, during the open label studies, this report came out of the interaction of cannabidiol with clobazam, where out of 13 out of 25 children who tried on cannabidiol, they were indeed on coexistent clobazam. And norclobazam levels that were measured were increased with cannabidiol treatment in 12 out of those 13. And many of the side effects that were noted could indeed be attributable to the metabolite of clobazam: drowsiness, ataxia, irritability, urinary retention, and tremor. In the original dose-finding study, which was actually published after the randomized controlled trial, they looked at the addition of cannabidiol in Dravet syndrome to those on clobazam and also with or without stiripentol. And when they looked at the change of norclobazam levels from baseline, certainly if the cannabidiol was added, then there was an increase in norclobazam levels. But if they were taking stiripentol, if they were not taking stiripentol, that same increase would be seen. But if they were taking stiripentol in combination with clobazam, the same increment in norclobazam levels was not seen, suggesting a saturation effect of the cytochrome P450 system. This was a recent meta-analysis published in Epilepsia that tried to evaluate the data across all the studies to see whether there was an independent effect of clobazam or whether all the evidence was that independent effect of cannabidiol, or whether all the effect was that what would be seen with combination with clobazam. And certainly if they looked at whether there was clobazam presence or indeed no clobazam presence, there was very little difference seen between the results, still favouring cannabidiol in causing benefit in the populations with epilepsy. And their conclusion from this systematic review and meta-analysis was that cannabidiol has an independent anti-seizure activity and efficacy, irrespective of clobazam administration. And this is our own personal experience with our original open label study, utilising Epidiolex on a compassionate use at the same time that the original US open label study was undertaken. And certainly we had no difference in responders with regard to whether there was clobazam or not. In fact, we had more in the non-responder group that had concurrent clobazam than we did in the responder group. So where are we now with cannabidiol, or Epidiolex, which is what the compound that's been produced by GW Pharma? It was approved by the FDA in June 2018, and the EMA approved in July 2019 in combination with clobazam. So there is a difference across the world as to how cannabidiol is, as Epidiolex is indeed licensed. And of course, it's licensed for seizures associated with Dravet and Lennox-Gastaut syndromes. But we continue to get asked by families about utilisation of other products. Cannabidiol has enriched oils, as hemp oils have been utilised as dietary supplements for a long time. And these have been determined from health food shops, have been able to be purchased on the internet. And families self-source these and have reported that they have seen benefit. These are not prescribable, they are not medicinal pharmaceutical products. And indeed, there's no particular quality assurance in the production of these different compounds. As cannabidiol is not a controlled substance, and particularly in the EU and in many other countries of the world, and that has particularly also changed over recent years with the utilisation of cannabidiol-enriched oils and cannabidiol as a pharmaceutical preparation. So there are many different cannabidiol-based products that are produced and are therefore available. But analytical controls aren't mandatory. There's no legal protection or guarantees, and no obligatory testing in order to determine dosage, route of administration, or maximum recommended daily dose. There are also clinical preparations that are prepared by pharmacies following medical prescriptions, where set particular flowers can be provided, and set pharmacies then make up the oils utilizing these so that there's a specific concentration of cannabidiol and THC. There is particular extraction methods that are used, but then there are a variety of different other compounds that will be also in these preparations, not least terpenes, flavonoids, and other phytocannabinoids to varying degree. And there's a lot of interest, particularly amongst families about, and the cannabis community, about terpenes, as that they represent the largest group of the cannabis phytochemicals. And they do have the ability to cross the cell membrane, the blood-brain barrier. And there has been discussion, although not proven, about entourage effects between cannabinoids and terpenes, and therefore a theory put forward that whole plant extracts are required rather than pure compounds, for example, of cannabidiol. However, with the oils that are produced, the hemp oils, and also, as I'll come to, the galenical preparations, there is an huge variation in the quality and the safety of many of the preparations. And in addition, difficulties with regard to labeling. Labeling isn't accurate. Cannabidiol concentrations are not always in accordance with producer information. And therefore, there is a need at the present time for stricter controls. This particular study looked at 14 CBD oil preparations produced in different European countries and obtained over the internet, and tested with regard to the concentrations of products. And indeed, 9 out of the 14 tested samples presented concentrations that differed notably from the declared amount on the label, although 5 out of 14 did have preserved CBD levels with the variation of less than 10%. And this study, performed in the US, obtained different products over the internet, not least cannabidiol-enriched oils that had less than 0.2% THC allegedly, and again found wide variability of not only the content, but also the labeling with regard to the content of those products. And even taking products whereby the flowers are produced with the specific concentrations or relative concentrations of THC and CBD, so that pharmacists can actually make up these products according to prescription. When this study looked at different products from different pharmacies, even though they had the same natural product, they had actually wide degree of variability of the concentration of CBD and THC in the final products used. Now, one of the key questions, having lots of data with regard to cannabidiol, is the THC required? And there has been concern about whether it's not only required, but is it safe? Tetrahydrocannabinol is the psychoactive component of the cannabis plant, and therefore there are concerns about what effect it may have on brain development, particularly, of course, in children with complex epilepsy. We know with cannabis utilization in pregnancy, there is a varying degree of effect on the infant, whether it's be prenatal, neonatal, or even determined memory and learning and cognition issues in infancy and later childhood, acknowledging that this is full cannabis use in pregnancy rather than isolated products. Also, if cannabis is utilized at a younger age, then there's more likely to, or started at a younger age, it is more likely that they will have cognitive performance issues than if the cannabis use starts at a later age. This utilization before the age of 15, showing the group showing more perseverative errors and other errors utilizing different cognitive performance tests than those where there was an older age of start of use. Again, I acknowledge this is full cannabis use, not the isolated products or reduced THC content. But there is also put forward that with utilization of full cannabis, there can be a distortion of the normal brain development processes right the way through into adolescence. And certainly this is a theory put forward with regard to cannabis-induced schizophrenia, in the fact that there's a distortion of the maturation, the dysregulation of the maturation of the endocannabinoid system induces changes in residual pruning, which would be expected through adolescent years. And therefore, along with distortion of glutaminergic transmission, then may lead to the frontal lobe abnormalities and consequent executive functioning abnormalities that may be seen. Oops, bear with me. Not quite sure what happened there. And although there are those that advocate that the combination of cannabidiol with tetrahydrocannabinol, although tetrahydrocannabinol is noted to cause a degree of cognitive problems, combination with cannabidiol may attenuate those problems. It doesn't reverse the problem completely. So at the present time, the concern is, number one, do we need the THC? And number two, is it safe to administer in a developing child? So we dealt with the concerns about cognition. What evidence do we have that we need the THC? Where there are no randomized controlled trials of looking at CBD with THC in treatment of epilepsy. There are open label studies, not least this one from Israel, that was a retrospective case note review looking at cannabis-enriched oil utilized across 4 centers in the treatment of epilepsy, with a 20% CBD and 1% THC in the cannabis oil. And you can see that with regard to seizure response, 34% had a 50 to 75% reduction in seizures, 17.5% more than a 75% reduction in seizures. This percentage of improvement is not dissimilar to that seen in the randomized controlled trials, acknowledging that these are open label studies and therefore subject to a degree of bias. And this study, a prospective study, open label study of CBD with THC in a ratio of 100 milligrams per mil of CBD and THC 2 milligrams per mil. This was in Dravet syndrome. So it was a prospective study in 20 children with Dravet syndrome. There was a 4-week baseline, 20 weeks intervention, and 60% showed a more than 50% reduction in seizures. Again, yes, higher than what we saw in the RCT, which was about 48%, but considering this is an open label study, perhaps not dissimilar to that seen in the RCT. And if we look at this, which is the responders and non-responders, so those on the left were the non-responders, whereas the bar charts go below 0, showing an improvement in seizures over the final 4 weeks of treatment. It's a very similar chart to what we saw in the open label study with cannabidiol. And this systematic review tried to look at all the data and with regard to cannabidiol and cannabis-related products, albeit that there were no RCTs other than those with cannabidiol. But certainly when they evaluated studies where they could be included in meta-analysis with regard to efficacy, there was a favouring of cannabidiol over placebo. That's what we've seen from the RCTs. But when it came to side effects, looking at cannabidiol rather than those products that included other things other than cannabidiol, certainly the side effect profile was markedly increased, and the side effect profile was favoured on the cannabidiol rather than the products that included more in the way of content. And finally, I just want to highlight this study. 75 patients enrolled. This is in Colorado, where cannabidiol products were legalized a lot sooner than other areas of the United States, which meant that there were those that were local that utilized products, but there were also families who were quite desperate to seek these compounds who moved to Colorado to seek these products. In evaluation of these patients who came to the hospital, 57% reported no improvement in seizure control. If the family had moved to Colorado for cannabis, the responder rate was 47%, but only 22% for those who already lived in Colorado, suggesting the degree of placebo effect and indeed the degree of bias, the buy-in from having moved to Colorado and much more likely to get a benefit than those who did not, and the buy-in perhaps hadn't been as great. So although I acknowledge we have evidence base for cannabidiol, the evidence base for cannabidiol with THC at the present time is not there. And not that I'm saying that we should not be looking at it. Certainly, of course, we want to advocate for new treatments where possible, but there is a need for randomized controlled trials for any of these products in order to move forward. So in summary, there is a place for cannabinoids in the treatment of the epilepsies, dependent on how defined and how indeed we utilize them. They are not a panacea, contrary to what many of our families might believe, and the appropriate formulations need to be utilized and indeed monitored. There is no current evidence for a requirement for THC. There is evidence based for use of cannabidiol, pure cannabidiol in the treatment of the epilepsies, but not for the addition of THC. And we need to evaluate that both with regard to efficacy, but also with regard to safety in our patient population. So there's no doubt that further study is required. Thank you.
Thank you, Professor Cross, for your presentation. We have several questions. Some of them you have already discussed during your presentation. There's a question regarding if there is any report, either positive or negative, interactions between CBDs and other commonly used anti-seizure medications or other medications such as birth control pills or devices.
I think at the present time, I think there's no question that there will be other interaction with medications that would be metabolized in the liver, not least through the cytochrome P450 system. So I've seen an interaction with perampanel, for example. I think what's unclear at the present time is the degree of interaction, for example, with the oral contraception. And I think we would have to be wary and we would need pharmacokinetic studies to look at that.
Okay.
I think there's a lot of, this is a major concern, well, not least in individuals who come to my clinic and they say they've either been prescribed elsewhere by somebody or they've taken their own oils because of the interaction with medication. And that's what I try to explain to my patients. It's not just a case of, is this going to be safe? Is it going to if you're going to have a consistent product on a day-to-day basis, but also the interaction that needs to be monitored with other drugs. And this is something that's seen in other areas. For example, in oncology, there's a huge degree of concern about the amount of interaction there will be with their medications.
Okay. Does the CBD has any effects on interictal spikes or any changes on the patterns found in Lennox-Gastaut syndrome, e.g.?
The EEGs weren't systematically reviewed, and I think what we've seen in other studies is that you may see some degree of improvement when you see an improvement in seizures. So there is a report of increased alertness, increased awareness, but we haven't got any definitive data with regard to any change in the EEG.
Do you think that CBD has any epigenetic changes over those genetic determined epilepsies? Because we have seen increasing numbers of publications regarding CDKL5, TSC complex, SCN1A mutations. But it's not clear whether it's the CBD itself working on a neuronal level or it's an epigenetic. Do you think it has something to do with that?
I think the fact that we see it across many different types of epilepsy, and indeed even in Aicardi syndrome, where it's a brain malformation, yes, there's a degree of genetic component, but it's a brain malformation, suggests that it's not isolated to an epigenetic phenomenon. I think we have to look at cannabidiol as an antiepileptic drug and having an effect regardless of the cause of the epilepsy.
Okay, there's another question regarding the evidence on efficacy in other refractory epilepsies, especially those focal in adult epilepsies. And the other one is related to how long should we treat patients with CBD if it works?
Okay, I'll take the second question first. I mean, if CBD works, again, it's an anti-epileptic drug. We've got no evidence that it's causing a disease modification effect. So, I mean, it would be like any other anti-epileptic drug that we continue it for as long as it's of benefit. Surely, if individuals become seizure-free, which I have to say in the complex group is extremely rare, you have to evaluate whether you're going to wean it off in due course because of the risk of actually seizures returning. And in many of these complex epilepsies, there's a high risk of them returning. So I would be very wary about weaning it off. With regard to adults and focal onset epilepsies, I know that there was a study initiated with regard to cannabidiol, which actually did not show benefit. But other than that, adults with focal onset epilepsies are yet to be evaluated.
Okay, you mentioned a study that used CBD on fires. How do we introduce CBD in the ICU or PICU setting? We need to escalate the dose very quickly. How do we start with that?
We use it orally. There isn't an IV preparation. So their gut has to be working and they need to be absorbing. And yes, we escalate it to 10 milligrams per kilogram over a 5-day period. Obviously, we also need to watch the liver function. And if there's liver dysfunction, need to monitor that quite carefully. But again, although the transaminases may become quite deranged in fires, often they're not on valproate and it's not a particular problem.
Okay, there's another question regarding adults. The dosage will be per kilo per day or will be like standard dose of 200?
I think the general thing is that it goes up to a maximum of 600 milligrams twice daily. So you build it up to 10 per kilo, but then there's a maximum dose of 600 milligrams twice daily. That aside, there are some individuals who may go higher than that, but that is what would be the suggested dose.
Okay, some of the most conservative pediatric neurologists are concerned relate to cognitive function of CBD in the long term. Do you think that's a problem with CBD, or it's only a problem with the THC products, or how we should address that?
I think, I think the evidence we have is that cannabidiol doesn't have a particular effect, and we've got data from psychiatric studies with regard to that. So the main concern is with THC. That aside, I think if we're going to be looking at this in the future, then we should be evaluating it in older individuals who are cognitively more able, and indeed thereafter, evaluating both cannabidiol and cannabidiol with THC.
Okay, and do you think CBD products have had an impact on SUDEP because it's used on a compassionate level on refractory epilepsy that may have a higher risk of SUDEP?
I think that I don't think we've got the data for that. I think obviously, one of the major risk factors for SUDEP is recurrent convulsive seizures. So by reducing that, I would hope that we are reducing the risk of SUDEP, but we haven't got data on that at the moment. Okay.
Well, I think there are no more questions, Professor Cross. So thank you again very much for accepting our invitation on this particular date, and thank you very much.
Okay, no problem. Thank you.
Bye-bye.
Thank you for having me.
Thank you. It was amazing again.
Is that